right, so now we're turning to the quality assessment of the physical therapy. Let's welcome David Wang.
Good morning, everyone. Today I'll be sharing our research on PhysiQ off-site quality assessment of exercise in physical therapy. I'm David Wang from Vanderbilt University and had the pleasure of collaborating with Professor Meiyi on this project. So a little bit quick introduction of the physical therapy as you've seen in the title. Physical therapy focuses on recovery and rehabilitation after injury or surgery. To illustrate, let me introduce you Jeff. So consider Jeff the patient, a man in his mid-40s who recently injured his shoulder, rotator cuff, for example. Post-surgery, he engaged a therapeutic routine prescribed by his physician. Jeff attends sessions 3 times a week, and the therapist instructs him on specific shoulder exercise to build strength and ask him to continue to do this at home. So however, in daily basis at home, Jeff faces challenge of performing this exercise, uncertain if he's doing them correctly. He was worried if his shoulder is moving high enough or not high enough. He was worried if he was doing too quickly or slowly compared to what he did in the clinics. And he tried to record the video of himself, but he's injured, so he's very struggling to position the video camera. So from this scenario, we can know with Jeff that it's evident there's a significant challenge, especially when he attempts this exercise unsupervised at home. This situation prompts a crucial question: how can we leverage technology to enhance the quality of Jeff exercise when no professional oversight is present? And after our literature review, we found there's noticeable lack of solution for home-based physical therapy, and current methods for therapeutic rehabilitation are limited. And lastly, the vision-based devices are often for short inconvenience or adequacy for users who are injured. So therefore, we asked the question, how do we develop such a framework? A fundamental issue lies in the absence of quantitative metrics. How do we precisely define these quality metrics? How do we cater to individuals from various backgrounds? Someone who are older might have different quality compared to who are younger. Additionally, our research revealed a significant gap. There isn't a data set that is available encompassing the quality of metrics that were identified. So to tackle this challenge, I'd like to highlight the primary contribution of this paper. To our knowledge, we present the framework that employs a smartwatch for assessment of quality of exercise. We digitalize 3 fundamental exercise metrics: range of motion, stability, and repetition. These metrics provide insight into functionality of skeleton system by building upon our understanding of the muscular system. We also develop a system to bridge patient with their physician more effectively to help them better understand their own exercise. Moreover, we designed a There we go. We also develop multi-task spatio-temporal Siamese network, which I will talk about in the next slide. Not only measures the absolute quality of exercise, but also its relative quality. We curated motion data from 31 participants, and the data encompass 3 specific shoulder exercises: shoulder abduction, external rotation, and forward flexation. And for fun fact, I drew this all by myself. So expand on the Jeff scenario, it's crucial to understand that our objective is never to substitute therapist. Instead, we aim to establish a reference, a benchmark, or in this case, an anchor to guide patient correctly. Our Siamese network is equipped with anchor exercise as shown here, which represents optimal exercise executed at clinical supervision. Once they are at home, Jeff can engage this exercise without direct oversight from our system as a signal exercise. And they are compared against our network, which integrating sliding window, CNN, LSTM, and the addition mechanism, ultimately producing a embedding. For those who are unfamiliar with the Siamese network, let me tell you a little bit more on that. They are architecture with 2 identical sub-networks, meaning they maintain same parameters and weights, same on the top and the same on the bottom. Traditional Siamese neural network often output binary classification, indicating the 2 inputs are the same or not. In our case, we output a continuous score between 0 and 1, representing exercise similarity. And not only that, our system employs an embedding of singular exercise to categorize its absolute quality. So I want to quickly dive into how do we digitalize quality, right? This is the most important part. How do we quantify that? So our primary tool for assessing similarity, as seen in the equation, is trying to align our anchor exercise. The Q term is the absolute quality, like range of motion, instability, or repetition. Again, the goal is to ask Jeff to be close to what he can do in the clinics, but not to overdo himself. And transitioning, we also need to know repetition. Our goal is to discern the starting point and the finishing point of each repetition so that the highest energy point will be shifted to the beginning and the end so that we know where the repetition starts. And lastly, we also have instability, which utilizes the coefficient of variation to quantify variability of the user performance. And we have collected our data set of quality of exercise with 31 healthy participants from age 18 to 44. We evaluate our system in various aspects, including standard split, live one now cross-validation, hyperparameter tuning, and the ablation study and the user study. Due to the time, I'm only gonna share what's shown on the red, and with some different baseline. Lastly, we also have 3 different metrics, and I will only focus on the R-square as indicating the relationship between the observed and a predicted value for continuous value. And utilizing a standard approach for comprehensive evaluation, we aim to assess the relative quality of this exercise compared to other baseline. And our framework demonstrates superior performance across all 3 metrics, particularly noticeable in performance on the R-square metrics, revealing a robust correlation. Additionally, we also have this bar graph, which represents the axis denotes each subject's ID as the leave one out test case, and the y-axis showcases the R-squared metrics result. The objective here is to gauge the performance of our model on subjects that it hasn't encountered. So what is the takeaway? We're trying to understand how to utilize wearable device to help patients to improve their at-home exercise due to its limited supervision. We work with therapists to understand what is the quality and how can we digitalize the quality. And last, we're trying to help users to emulate what have been done in the clinics and not to overdo themselves by creating a Siamese neural network to effectively providing score as feedback to the user and compared to their own exercise. Well, due to the time limits, I'm gonna quickly go through this. It's very important to emphasize the personal quality in physical therapy, and we also want to greater access to remote physical therapy. And it's very, using comparison can help us to enhance the monitoring system. And there are other things such as how do we apply this to the general exercise or sports, or using different modality of sensor. And lastly, how can we explain the rationale of the model? And thank you so much. This is my presentation.
Thank you so much. All right. Time for one question.
Thank you for the great presentation. I just want to clarify, how does your similarity cell account for different anatomical feature of people, like taller, shorter, longer arms?
Yes,
so on?
So that's where the anchor exercise come in, right? The model seeing 31 participants. For example, in this case, we're seeing the 31 participants, and they use the anchor exercise only is for that particular subject. Like they did it in the clinical, so that when the data is going to be used when they compare it against, that's your own data. Right? Again, you're not trying to overdo yourself by your own data, if that makes sense. If that answers your question.
So whenever it actually changes over time, so you still calculate the scores, it should be okay then.
Yeah,
over time.
and your anchor is changing constantly as you're going back to the clinics, right? The whole thing's, right? Because you're injured. You're not trying to do better what you can do in the clinics. You're trying to see how similar you are to the clinics.
Right. Thank you so much. Right. All right. So how many of you actually ever painted something? Okay.